Hello, everyone, and welcome. My name is Dr. Lisa Martin, and I am your MC for the day. Before we get started, I want to go over a few housekeeping items. If your screen freezes or you lose audio, please refresh your browser and be sure to log in via the Chrome Internet browser for the optimal viewing experience. Closing any other operating programs or windows may help with your viewing experience as well. Please feel free to use the chat function for any questions that you have during our forum, and we'll do our best to respond to you. Please include your email address when you post a question. That way, if we don't get to respond to it today, we can follow up with you. This program is being recorded, and you will be able to access it on the Campaign for Action's website within the next week. Please be sure to check out our resources, which you can access through the toolbar found at the bottom of the Intrado platform. And now it is my pleasure to introduce to you a wonderful nurse and leader, Dr. Susan Hassmiller, Senior Advisor for Nursing and Director, Future of Nursing, Campaign for Action, Robert Wood Johnson Foundation, Senior Scholar in Residence, and Senior Advisor to the President on Nursing, National Academy of Medicine.
Good morning. I am Sue Hassmiller, the Senior Advisor for Nursing at the Robert Wood Johnson Foundation and the Director of the Future of Nursing Campaign for Action. On behalf of the Robert Wood Johnson Foundation and the Campaign for Action, I'd like to welcome you to the third and final Health Equity Action Forum. The first two forums sparked fruitful discussion, and we are encouraged by your participation and the continuing conversations that we've had with many of you. The first Health Equity Action Forum brought together businesses, government officials, policy leaders, social justice and consumer organizations, healthcare providers, and nurses to discuss the importance of engaging and activating a diverse range of stakeholders to support a more diverse nursing workforce as a means of advancing health equity. We learned how nurses as trusted partners can participate in programs and partnerships that advance health equity. An excellent example are the Haitian nurses who are hosting virtual baby showers for the Haitian community in Broward County, my hometown, Florida, sponsored by the Broward Healthy Start Coalition and the Urban League of Broward County participants who attend these free events, learn from nurses who speak their language and understand their culture about healthy pregnancies while enjoying virtual vendors, raffles, prize giveaways. The second Health Equity Action Forum demonstrated how nursing can be an effective career ladder to achieve financial security for historically marginalized populations. It's also critical for the care of people in these groups that we build more diversity and inclusion in nursing. That requires a concerted effort to provide the mentoring and other supports these nursing students need to gain admission to nursing programs, persist through graduation, and succeed at the NCLEX licensing exam. This also requires more diversity among our faculty, deans, directors, and chief nursing officers. Well, this will be the final Health Equity Action Forum. The National Academy of Medicine will release in May, most likely during Nurses Week, its long-awaited report, The Future of Nursing 2020-2030, charting a path to achieve health equity. To succeed, this report will require the collaboration of all of you and many other partners. We invite you to attend the virtual release of the report, most likely on May 11th. In my role as senior scholar with the NAM, I am working with their communications team to develop supplemental educational materials. More details will be forthcoming, so stay tuned. And on June 3rd and 4th, the campaign will virtually host a major stakeholder meeting to chart a path forward for implementing the new report recommendations. We invite all to attend, including our action coalitions, campaign leadership and committees, nurses who work in every practice setting, nurse champions, policymakers, and health and social justice stakeholders alike. It will take all of us to advance health equity, and I hope you will join us. I am delighted now to turn things over to my friend and colleague at the Campaign for Action, Dr. Susan Reinhardt. She serves as the Senior Vice President and Director of AARP's Public Policy Institute and as Chief Strategist for Family Caregiving Initiatives. She also leads the Center to Champion Nursing in America, an initiative of AARP, Foundation, AARP, and the Robert Wood Johnson Foundation. Susan?
Thanks, Sue. And thanks to all of you who are joining us. I'm sure many of you, like me, were very happy to see the COVID-19 relief package signed into law this month. Took a while. It provides significant funding for nursing in the form of educational loans and scholarships, public health workforce funding, and nurse home visiting programs for mothers and babies, which have been instrumental in advancing health equity. My team is working with the National League for Nursing and the American Association of Colleges of Nursing to host an informational webinar featuring HRSA's Division of Public Health. And it will explain how students and individual nurses can apply for these educational dollars. We hope to post those details pretty soon. And I also want to mention the inspiring, really inspiring summit the campaign held on February 24th. It was amazing. 1,200 nurses and nursing allies joined us with representation from all 50 states, Washington, D.C., and a dozen countries. We were honoring the nurses who have been serving on the front lines of the pandemic, and we reviewed the decade of progress our profession has made in partnership with all of you. If you missed it, or either of our earlier health equity action forums, I really encourage you to view the recordings and access the resources we posted on the campaign's website. That's also where you'll find information about our upcoming events, including the HRSA webinar I just mentioned, and the national meetings Sue mentioned on June 3rd and 4th, where we'll talk about how to implement the recommendations of this forthcoming Future of Nursing report. So now let's turn to today's forum. We had hoped that Dr. Bernadine Lacey, who is an American Academy of Nursing living legend, would be joining us today. We want to honor her today. Here are some photos we have of Dr. Lacey from her work with us on mentoring support program for HBCUs. And as you can see, Dr. Lacey means a great deal to our staff and established a mentoring relationship with Jasmine and Scott. To get a sense of what she would have shared with us today, Dr. Lacey suggested that we each read the American Journal of Nursing article from August 2020, which is titled, "You Have No Business Being This Good," an oral history interview with Bernadine Lacey. You can find a link to this article among the resources in the resource section on this virtual meeting platform, and you can also find it on the Health Equity Action Forum landing page. Just go to www.campaignforaction.org. To bring you all three of these Health Equity Action Forums, the campaign has partnered with AARP's Office on Diversity, Equity, and Inclusion and Global Thought Leadership teams, led by my dear colleagues, Edna Kane-Williams and Dr. Jean Axius. We're extremely grateful to Edna for lending us the expertise of AARP Vice President for Latino Audience Strategy, Yvette Pena, and for Jean's teammates, Dr. Erwin Tan and Melissa Grober-Morrow, who were influential in shaping these events. Earlier this month, AARP deepened its commitment to diversity, equity, and inclusion by creating a new division in AARP known as Diversity, Equity, and Inclusion, and appointed Edna Kane-Williams to the role of Executive Vice President and Chief Diversity Officer. I really think our AARP founder, Ethel Percy Andrus, would be incredibly pleased by this. She was a champion of communities of color from the start of her career and would no doubt approve of AARP's steps to fully integrate all demographic groups as we work to empower people to choose how they live as they age. And now it's time to move on to our fireside chat. It gives me great pleasure to introduce our first two guests. Rear Admiral Susan Orcega is the director of the U.S. Public Health Service Commission Corps nurse practitioner and has served as acting Surgeon General since January. And I'll say more about Susan in a moment. She is joining my esteemed colleague, Lisa Marsh Ryerson, who is president of AARP Foundation, which is the charitable arm of AARP, and along with the Robert Wood Johnson Foundation, has been a pillar of support for the Campaign for Action. As leader of the AARP Foundation, Lisa has spearheaded pioneering initiatives to realize the Foundation's vision of a country free of poverty where no older person feels vulnerable. And she always says that nurses have long been a key part of that vision and remain so today. So a little bit more about Rear Admiral Ortega. She is responsible for directing all functions regarding personnel, operations, readiness, deployment, and policy for the United States Public Health Service and development of the Reserve Corps. The U.S. Public Health Service Commissioned Corps is comprised of approximately 6,000 uniformed health officers who serve in nearly 800 locations around the world, promoting, protecting, and advancing the health and safety of our nation, including the activation of the United States Public Health Service Commissioned Corps to support national COVID-19 vaccination efforts. She previously served as the United States Public Health Service Chief Nurse Officer, advising the Surgeon General on the recruitment, deployment, and career development of 4,500 nurses. We are delighted to have both of you with us today. And so, Lisa, I'm turning it to you to take it away.
Thank you, Susan, for that introduction. It's so nice to be with you again today. And thank you to Rear Admiral Ortega for your public health service as acting U.S. Surgeon General. It is such a wonderful treat to see a nurse in this important leadership position. And now I'd like to turn the floor over to you, Rear Admiral, so that you could share a few words.
Great. So before I begin, I want to offer a sincere thank you to you, Lisa, Drs. Hassmiller, Reinhardt, Quinn, and Mrs. Boyle, Pete, and Polanski, really for facilitating this forum, the organizers, and allowing each of us to share our perspectives on health equity action. My deepest gratitude to everyone who's watching, who's been on the COVID front lines, and for allowing me to speak to you today. Across this country, the pandemic has exposed deep-seated divides within our communities, and data from the Centers for Disease Control and Prevention shows that Black and Latino populations who contract this disease are dying twice the rate of other populations. And additionally, we know that health status of many populations, Hispanic, Asian Americans, African Americans, and other minority populations, such as American Indians and Alaska Natives and Native Hawaiians and other Pacific Islanders has long lagged behind that of non-Hispanic whites. For a variety of reasons, older adults in these groups, many may experience the many effects of health disparities more than younger people. And nowhere are these facts more deeply felt in hard-to-reach rural paths in the Appalachia or in rundown urban streets in Chicago, where those living in poorer communities struggle daily with access to medical care amid the worst pandemic in more than 100 years. And both areas, while they're divided by these extreme distances, the population shares a common capillary connection. They struggle with limited access to mental health services, have difficulties related to language, health literacy, and insecurity due to lack of health immigration documentation or not feeling comfortable asking for assistance. And lastly, they usually lack medical insurance. Coupled by the burden of COVID-19, these populations share and suffer from higher rates of hypertension, diabetes, and obesity. And according to, adding to the problem and due to the digital divide, many of these residents just don't have internet access, own a computer, or even have access to a smartphone. As the world exceeds 2 million cases and the nation has exceeded 500,000 deaths, and mortality numbers are exceeding 3,000 deaths per day, it's no small thing to create a nationwide vaccination program. We must continue to push for a faster and a more equitable vaccine distribution at every turn. And while it's easy to unmask this effect related to vaccination rates, the same forces play out through the entire healthcare system. The America the Beautiful song evokes patriotism, and it hails to pioneers. The lyrics, "Oh, beautiful for heroes proved in liberating strife, who more than self their country loved," references the soldiers who fought for their country. The similarities are striking as we storm the surge of COVID-19 as America's heroes, health warriors offering hope during a time of hurt and hurdles from the lack of equity, care, and access.
Thank you, Rear Admiral Ortega. I would first let you know that I will forever sing that song and hear it in a new way. So thank you for that. But today, I'm so looking forward to discussing with you the issues that you raised about health equity. As you know, these issues have been of deep concern to AARP as we work to build a better future for all people as they age, and also for AARP Foundation with our focus on eliminating senior poverty. Of course, discrimination and racism play a big role in poverty, and they have been front and center over the last year as the pandemic has ravaged our nation. Nurses have borne witness as the tragic disparities in health and access to quality health care that have plagued our country for so long have come to light. And the past year has thrust issues of racial discrimination and inequality to the center of the conversation as we watch the pandemic exact, as you noted, a highly unequal and devastating toll on communities of color. Health disparities have never been more evident or more on people's minds. And these disparities in who gets sick and who dies, who gets care and who does not, as we know, did not suddenly appear with COVID-19. They have been here all along, hiding in plain sight. To tackle these disparities, we must focus on the social determinants of health, factors such as education, access to health care, jobs, housing, food, and social isolation. These factors affect people's health from cradle to grave. And because we know that nurses are so closely involved with patients, they have a window into the social determinants that often cause great damage to patients. And as part of the healthcare system, they are well positioned to create and to be active members of the solution. Many nurses have not received the recognition they deserve for their pivotal role in improving our nation's health. And so today, you and I will be discussing some of these nurses today and the critical role that all nurses have played in addressing health disparities, which are issues AARP and AARP Foundation are very familiar with and to which we have long been committed. With your background as a nurse, with your important role as acting Surgeon General, I know that they are a high priority for you as well, Rear Admiral. And I also realize that for many of you who are listening today, health disparities are not abstract topics, but are part of your lived experience. We need to consider social justice in the context of COVID-19 and its impact on healthcare workers. A majority of COVID-19 deaths have been among Black and Latino people, and 40% of COVID-related deaths have occurred in nursing homes. And far too many nursing home staff have died as well, predominantly people of color. Nurses have been disproportionately effective, and Filipino nurses have borne the brunt of deaths among RNs. And we'll discuss this tragedy later in the program. Healthcare disparities have clearly played a role in this unequal and tragic pattern of death. So let's dive into our conversation, Rear Admiral Ortega. And I want to start with you and have a conversation or learn from you, from your point of view, what role can nurses play in helping individuals and families, but also communities who have been and continue to be hurt by healthcare disparities, by racism and social injustice.
So, Lisa, thank you so much. I mean, this is such an important topic. Certainly witnessed it firsthand back last year in March, and certainly catapulting forward. Under President Biden's plan, one of his big priorities is the COVID-19 vaccine rollout. And looking at December 8th in 2020, his plan, he spoke about 100 million shots in the first 100 days. And it was guided by science and to get the vaccines to those of the greatest need. And that would have been 1 million vaccines a day. And, if you look at March, we're at 2 million a day, but we still have a long ways to go. So it's our societal and really our social obligation to provide these solutions focused on equity, access and pathways and support across all the populations. And so when I think of nursing and for healthcare, the solutions are really in our professional parachute. And I believe that it is our tools in this parachute that will allow us to work across all of these settings. And it's not just a stethoscope or the electronic programs in our iPhone or our books that we refer to, but it's leveraging that set of core leadership skills that allows us to turn that dial towards a healthier nation that's driven by care for all, with that backdrop of really being COVID right in our mind. And so my unique experiences working in African countries and disasters has really led to my belief that you need these leadership skills to work in challenging and complex healthcare environments, working with vulnerable populations, whether it's domestically or globally, and daily or even during disasters. And so our nursing leadership skills, and really, quite frankly, any healthcare professional, needs to be in our ability to work collectively across all the professions and across the world to solve these clinical and scientific and community challenges. So I'd like to name a few examples. The National University Nurse Managed Clinic is just one example of a trusted care provider in Los Angeles. It actually represents a robust framework and is a model built upon trust of some of the most local level of healthcare system communities. We need more of these nurse-led clinics across the country. And the second is really, I think, about community leaders. And we know that in many urban areas where the sidewalks are unkept and crumbling and kids and adults don't get out to walk, they're sitting at home. And that's very therapeutic for us to get out and walk now when you think of COVID. And healthcare professionals are present at community housing boards, influencing that importance of walkable communities. But we need nurses at these community boards. And all of us need to work across all of these sectors that are non-traditional: government, city planners, community organizations, with educators, religious organizations, and other individuals to work together in this fabric of addressing chronic diseases and poor health habits, and really that rising unhealthy behaviors that we know are leading America down this path of a reduced quality of life. I mean, these are small but really powerful inroads that will drive us towards a healthier nation. Yeah, the next one is really collaborating. And when I think of the role of the United States Public Health Service collaborating on the front lines of COVID-19, it just can't be underscored enough. So many examples, but in a lot of times when you're out in responding, you may not have all those tools in your organization, but you have these other tools in your parachute within your profession and with others who have shared goals. So it was really a phone call that I made to Dr. Eileen Sullivan-Marks in NYU when the Corps needed nurses to receive real-time training, if you can imagine, for the use of ventilators before they were deployed to the Javits Center. I mean, that was just one of those absolute real-time moments. And so we have facilitators and representatives of public health initiatives, and all of us have this cauldron of care that we have to be able to connect with each other. And we have to have the ability to connect, with government programs and initiatives with community. And that's really what the Public Health Service does, is that in the uniform, that public health asset, which was a unique among all the services in the government. More people should join the Corps. I'm obviously biased, but the CARES Act has provided funding to the United States Department of Health and Human Services for the Ready Reserve, which is our uniform service reserve component. And the intent is we restructured this component to build out a reserve unit similar to other uniform services. So that, if you can imagine right now, the Reserve Corps provide additional trained, ready personnel of teams who could go out in short notice to fill those critical public health needs and be called up. Nurses by far are the highest in demand right now when we deploy for disasters or public health crises. This is not going to change at any point in the future of public health service nursing, or really any one of us within the profession. So originally, I'm from Pittsburgh, and I am.
Oh, a city I love.
That's great. And so I'm immersed. I was immersed really in growing up in Steelers football growing up, and I remember that the many plays at the last minute of the game, and as nurses, we don't have to do a Hail Mary throw to solve equity. Nurses have all the plays in the playbook. And with our rich history and our Super Bowl MVP nurses to reference, and we can be the public health pandemic quarterbacks. We just have to be determined to throw that ball with discernment. We can't be the wide receivers waiting for another profession or another individual to pass that healthcare solution ball for us to catch it.
It's interesting. Let's stay here for a minute. I think your response is so powerful, Rear Admiral Ortega. And I think about all of the elements when you're talking about how nurses can help individuals, communities, and families, and talking about trust and collaboration. I love your reminder about the strength of and importance of the core. It sounds like you're reminding us that these issues of building equitable health outcomes, of access to quality care for all, are contextualized in community. So maybe you'll talk about that a bit more. I appreciated what you shared about nurses joining other key organizations in their communities as a way to promote health at all times, not just when they're one-on-one with a patient in a healthcare setting, right?
Absolutely. And I think we sometimes get so focused in on the things that we do, whether it's at the bedside or the boardroom, that we don't stop and do that strategic pause to think we are that powerful catalyst, and being part of large organizations, whether it's the public health service. There are many other variety of opportunities that we all should be reflecting and thinking about so that we can make that continuum of sort of cashing in on leveraging equity and leveraging access, whether it is, like I said, the disaster or whether it's at individuals who need care at their doorstep. So it's under recognized, and certainly cross-sector collaborative and power of partnerships is integral. So I really appreciate it.
Yeah, I'm just so glad, and as you said, the context of the core, and when you reminded me that nurses are in high demand and asked for most frequently, Rear Admiral. On my mind is it's very hard, I think, during this time of the pandemic to find those bright spots. But you and I have known, certainly AARP Foundation and AARP have known about the power of nurses as leaders in public health and in building equity. And I'm really happy to hear that you're finding during this time that that's coming more to light. But as it relates to collaborations that you're talking about, I'll share a couple that we're really actively involved in at AARP Foundation that may be of interest or you may have questions about as well. One of the most powerful collaborations that we have at AARP and AARP Foundation with the Robert Wood Johnson Foundation is at the core of the topic we're talking about today. And it's about the future of nursing, the Campaign for Action, which is housed at the Center to Champion Nursing in America and led by my great colleagues at AARP, along with their colleagues across the nation and at the Robert Wood Johnson Foundation. And Rear Admiral Ortega, it is all about the imperatives that you spoke about in your opening and in answering my question to you of helping nurses be able to leverage the authority of their licensure and helping nurses be leaders in building equity in healthcare settings of every variety. It's a very important collaboration. You might also be excited to know about a group that AARP Foundation pulled together and founded with ProMedica, which is a nonprofit healthcare organization. And some years ago, as we were thinking about driving access to equitable care and addressing social determinants of health, we came together and founded the Root Cause Coalition, which is an organization of 70 organizations across every sector, all focused on driving scalable solutions for equitable health outcomes.
That's fantastic.
Terrific. Well, now I want to move on, and I want to ask you about some of your heroes in nursing. And in particular, if you would tell me who's on your mind when you think about the so-called hidden figures of nursing.
Yeah, no, it's really, that was really a tough question because there are so many heroes, and certainly when you think of right now, but really thank you. I mean, the Public Health Service has really this rich history of connecting, as I was mentioning before, with communities, and our mission to protect, promote, and advance the health of the nation. And when I sort of reflect on that question, I'm reminded to sort of think of history and pneumonia. Sure. In early 20th centuries, pneumonia was one of the serious concerns of the Public Health Service in the early decades. And interestingly, as a result of posters that were distributed across communities to increase awareness, cases decreased, if you can imagine, across communities, across the country. But there was a cognizance of the need to have more care. And in 1944, Surgeon General Perrin at the time, he appointed Lucille Petrie-Leone, and not very many people know her. She was the very first chief nurse. I was a chief nurse at one time, the very first female to wear the rank of a rear admiral in the uniformed services. And her job was to lead what was called the cadet nurses. And so I know some of your colleagues know the cadet nurse program, but if I can just take a little experience, sort of broadly talk about
Absolutely.
it. You know, the Cadet Nurse Corps, the largest training program of the nation during its 3 years of its existence, it literally provided a huge reservoir of trained nurses for military and in fact individuals who were coming across from the country out and coming across into the United States. And it really prevented the collapse of the civilian nurse services on the home front. I mean, these are and were still today the hidden heroes. I have to actually say, you know, one of my two hidden heroes is Minnie Carter. Miss Minnie Carter. She's a dear friend. She was a cadet nurse corps, and she member, and she worked during a time when most places in America didn't let races commingle in the workplace. African American woman who I'm astonished today to her recall of the ability in her 90s to talk about these rich experiences. But she talks about sort of working in these hard working, rotating shifts. And she shared to me that oftentimes she was the recipient of enduring, she endured these insults from her various patients, but she was focused, and she was focused on her mission to care for individuals. And sometimes she was the only Black registered nurse on duty, but she continuously transformed those events into positive learning environments. And it just experienced a prosperous and fulfilling career in nursing. In fact, she ended her career working at the place where I came from, at the National Institutes of Health.
Yes.
Just completely inspired by her fortitude and focus, and really was a catalyst. I have to then also sort of shift personally to my grand aunt, Aunt Connie. And so she too was one of those nurses who was working really when nurses were expected to work. Oftentimes we call it now the bench to bedside, right?
Right.
So she was required to examine patients at the bedside and then collect samples and then go walk down the hall and under the microscope look for these diseases. This really is part of their daily assignments. Just her focus and her energy and enthusiasm and her intellect. I was inspired and still inspired today because she took it all in, those challenges, but did it in a way that with that compassion at the same time was just understanding the importance of not bearing all the stresses with all of those challenges. And oftentimes I think about her when I am going into those complex environments. So those two public health nurses, Minnie Carter, experiencing the diversity challenges, and my aunt really helped to bring, they were the exemplar services within nursing, and really catapulted the nurses in line with really that underpinning of that best biological and social sciences learning that they experienced. And their professional ambition really had no barriers. And then when I think of some other nurses that some more common that I'm sure many know. In the 1980s, Dr. Faye Abdallah. So she was a deputy surgeon general. She locked arms with the Surgeon General C. Everett Koop to address the stigma of HIV and disabled. And as that first deputy surgeon general nurse, it was her innovation and sort of thinking about the risk of understanding the importance of disseminating work and out to the entire country. So what they did was they took the largest program ever took disseminated posters out across the country about HIV. So these two individuals really were focusing on improving health of the nation and really underscored the importance of futuristic multidisciplinary collaborators. So she advised them and like I said, sent this 8-page version of this report that was very simply stated, understanding AIDS, if you can imagine, across every single household, the largest mailing. So if you think of that, the first time, the federal government had provided this sort of explicit sex information to the public.
That's right.
Transformative, not challenged by barriers. And so these generations of nurse leaders really represented an approach, really a relentless approach in advancing nursing practice through excellence in education and leadership. And I see them as a guiding light, quite honestly, for our profession during COVID. Throughout history, nurses have been, champions for the less fortunate and the underserved. And, nurses really need to lean in as decision makers. Sometimes nurses' voices are not necessarily always heard at the decision-making table. And some of this is reality, but that does not mean that we should be silent or accepting. And we have the largest profession, the largest voices. We talk about it all the time, who really can make it possible for our measured success. So in closing, just as influenza shaped our history and our profession, COVID-19 will be that story of science, discovery, and how one changes the way we think amongst crises. And it should be that turnkey moment for nursing. We have to look back to look and to learn how to look forward.
Yeah, it is. I think you have helped us reach a point for a great wrap, Rear Admiral Ortega. And I have to say, I have learned so much in my dialogue with you today. I am so thrilled to have you as a leader as we're building, quality public health and addressing health disparities and building equitable access and, most importantly, equitable outcomes in healthcare. And then I say, as I think about your wrap-up comments, I'm going to offer up gratitude. Here we are in Women's History Month for Lucille Petrie, for Minnie Carter, for your Aunt Connie, and for Faye Abdallah, and for all of the nurses who are providing such exemplary service across this nation and who, as you said, have done that across time. It is tough to address the challenge of building true health equity, but with a reminder of where we've been and where we can head together, I'm happy to be in this with you.
Well, it's absolute my pleasure. And thank you for the opportunity to talk to you today.
Thank you for your leadership and for your service and for sharing your insights with all who are joining us today. Thank you.
Thank you, Rear Admiral and Acting Surgeon General Ortega, as well as AARP Foundation's President Lisa Marsh Ryerson. Hello again to our audience. We are now ready to move on to our conversations for the day. Let's bring on our first panel, which is being moderated by the past president of the National Association of Hispanic Nurses, Dr. Angie Millan. Angie will talk with several nurse leaders about racism and injustice on the health of the individual, family, and community. Joining Angie, the president of the American Nurses Association, Dr. Ernest Grant, Dr. Cheryl Taylor, associate professor, School of Nursing, Southern University A&M College, and a wonderful community-based nurse, Ms. Whitney Fear. Angie, it is so nice to see you. Please join us.
Thank you, Lisa. On behalf of the National Association of Hispanic Nurses, I am pleased to join the Campaign for Action and AARP's Office on Diversity, Equity, and Inclusion. We at NON have a terrific relationship with our AARP and CCNA colleagues, including a 2-day mentoring program we just hosted with 25 Hispanic serving schools of nursing. The mentoring program was a terrific virtual event that included 60 people representing deans, faculty, and even some recent graduates of Hispanic serving schools of nursing, along with representatives from the Action Coalition in the states where the schools are located, representatives from NON and the campaign. It was very engaging, and we all look forward to continuing this work through a monthly learning collaborative. Through this work, we hope to increase the number of Hispanic nurses in the field. As we have witnessed and heard from Lisa and Rear Admiral Ortega, we have a long way to go to achieve health equity in this nation. NON remains committed to achieving this most important goal, and I know many, if not all of you, are committed to the same, especially those joining me on today's panel. We have a variety of nurses representing practice, policy, and history. What we would like to do is set the stage today's conversation by hearing from Dr. Ernest Grant to hear what the American Association of Nursing is focused on regarding equity, diversity, and inclusion, and let us know about their plans for this important set of topics.
Thank you for having me. It's an honor to be with you today to discuss this very important conversation. On behalf of the American Nurses Association, which represents the interest of the nation's 4.3 million registered nurses, I would first like to commend the strength, dedication, and innovation of the nurses on the front line of this global pandemic. Nurses are on the front line of every major health crisis. Based on this long track record, we know that trusted and positive relationships lead to dramatically improved health outcomes. We believe that nurses and all healthcare professionals must leverage this trust and take a stand against racism, health disparities, and social injustices that divide our nation. Unfortunately, America's long history of negligence in providing equitable healthcare has eroded trust and ultimately causes communities of color to be suspicious of the healthcare system. To help address this and decrease the disproportionate COVID-19 infection rates, communities of color must have timely access to credible information. With the arrival of life-saving COVID-19 vaccines, we're hopeful that we have turned the corner. However, it's crucial that we continue to make a concerted effort to provide communities of color ongoing information and facts about COVID-19 vaccines and immunizations. Nurses serve as role models, and we are learning that people are more willing to get vaccines if they know someone personally who has received it. We have found that nurses sharing their COVID-19 vaccine experience as the rollout began was extremely beneficial to building trust and confidence. ANA urges Black, Latinx, and other nurses of color to connect with their patients, share culturally relevant information, and answer questions your community may have about getting vaccinated against this virus. As a nation, we must also recognize socioeconomic challenges that create barriers to access to care in our country and address them. I had the opportunity to share testimony last year with the House Committee on Ways and Means on the disparate impact of COVID-19 on these communities. We shared recommendations specifically related to COVID-19 and to address longstanding issues of racial disparities, such as the critical crisis of maternal mortality and basic access to health care, including mental health services. When ANA's highest governing body, our membership assembly, met in June of last year, I reiterated that it is the ethical duty of nurses to recognize human dignity and protect human rights. Further, demonstrating the urgency to take meaningful action, the ANA Membership Assembly adopted a resolution on racial justice for communities of color. The resolution reaffirms ANA's position against racism, discrimination, and healthcare disparities, and includes a number of specific areas where we pledge to take action. I encourage you to go to our website and read the full resolution. In partnerships with nurses everywhere, ANA has vowed to educate, advocate, and work together to end systemic racism, particularly within the nursing profession. The ANA Board of Directors also voted to convene a national steering commission to create a national action plan to guide the profession and combat racism in nursing. The National Commission to Address Racism in Nursing is led by the ANA, the National Black Nurses Association, the National Coalition of Ethnic Minority Nurses Association, and the National Association of Hispanic Nurses. The commission members and organizations represent a broad continuum of nursing practice, ethnically diverse groups, and regions across the country. Together, they will examine the issue of racism within nursing nationwide and describe the impact on nurses, patients, communities, and healthcare systems to motivate all nurses to confront systemic racism. Collectively, we speak with one strong voice as leaders and role models of compassion and empathy of our patients, families, communities, and more importantly, towards one another. Our voice is our commitment to making a difference. An ongoing priority of my presidency is to increase the diversity of nurses in practice to better reflect our nation's population. One way to accomplish this is by addressing systemic racism in nursing, and ANA is committed to implementing comprehensive strategies to address inequities. Nurses have a responsibility to help tear down the walls of racism. It is imperative that we lead by example. We must ensure that we are representatives of the patients that we care for, from bedside nurses up through those in the ranks of healthcare leadership. Our aim is for the nursing workforce to be equally representative of the diverse patient population it serves, and where all voices are heard and respected. As nurses, we must be the change we wish to see in our workplaces and communities. We must start early and eradicate stereotypes. One way that we can accomplish this is through Leadership Academy and training programs that educate and prepare future chief nursing officers, hospital administrators, and other healthcare leaders. Many of ANA's constituent state nurses association have already developed such programs with great success. Healthcare organizations should also promote educational opportunities for all employees. We have seen the power of nurses' voice, yet we know that there is much more to advocate for, not only to advance the profession and the quality of care, but also to advance our vision to access to high-quality, affordable healthcare for all. Leaders must come together at the local, state, and national level and commit to sustainable efforts to address racism and discrimination and basic human rights. We must hold ourselves and our leaders accountable to committing to reform and action. As president, I take seriously the responsibility to lead the ANA during these turbulent times. Thank you.
Thank you, Dr. Grant, for sharing ANA's efforts on addressing equity, diversity, and inclusion. I am now happy to introduce to you a nurse who's making an impact on the Native American women and families in her community, Whitney Fear. Please share with us the work you do, the population you serve, and the knowledge you include in your clinical care and intergenerational trauma and other factors and their impact on the well-being of Native American people.
Thank you for your question, Angie. I am a psychiatric mental health nurse practitioner, and I practice that at Federally Qualified Community Health Center, an FQHC. I am the sole behavioral health clinician with prescriptive ability, and I'm working in a community where it can be anywhere from 6 to 9 months to see a provider like me. I see patients of all ages, and I'm also a medication-assisted treatment provider. Something unique about my role in the organization that I work here for is that I started here as a nurse about 7 years ago. It was through the support and encouragement of the organization that really made it possible for me to pursue completing my education to be a psych NP. To be honest, I had a lot of imposter syndrome to overcome, and hearing from leadership that they believed in me and wanted to make that investment in me as a professional was something that was so encouraging. I knew if I took that leap into finishing my education that I only wanted to do so if I could practice using concepts like trauma-informed care, harm reduction, and focusing on the social determinants of health. And my organization has been really supportive in me doing that. Even though our program is still in the development stages, we are determined to be a fully integrated behavioral health program. Here, we're having primary care providers, dental providers, an optometry provider, nursing, pharmacy, and dietitians working together with our behavioral health team in order to care for all of our patients' needs. I love what I'm doing, and I believe that it is an approach that best serves any population, but especially the needs of disadvantaged populations. Since I work for an FQHC, the majority of my patients are individuals who are historically underserved and probably experiencing a significant amount of barriers to care. Some of my patients did know me when I was their nurse in our homeless health division here. I've taken on several regular therapy clients, although that's not my primary focus as a clinician. And I chose to agree to this because these individuals have a preference to have a diverse person that they see for therapy. I feel that it is an obligation to agree to this when it's appropriate because there's a burden on diverse people to make accommodations for their providers through doing things like limiting the intensity to which they divulge discriminations they're experiencing in order to avoid hurting their providers' feelings, and explaining the history of discrimination their people have experienced can be very taxing on them as well. So that problem is very rarely the fault of the therapy provider, as it is more often the case that these patients have had to spend most of their lives being uncomfortable in order to preserve the comfort of others who don't experience that same discrimination or injustices in life. I've had many patients tell me that they feel relieved when they find out that I'm Indigenous and that I grew up on the reservation. Because they know then they don't have to explain to me that discrimination exists in our country because they already know that from personal experience that it does. Some patients have sought me out because they've heard about my background and had felt for years that they would have a hard time seeking care from someone who was not a diverse person. I serve many populations that have had things happen like being targeted for genocide, experiencing systemic racism, and subjected to lifetimes of discrimination. Indigenous people share a commonality with many communities in the way that our way of life was unacceptable to the standards of colonialism, and we were seen as inferior as a result. There's no real way of communicating what type of impact there is to be a member of an ethnic group that was targeted for complete extermination, enslaved, and then subsequently denied basic human rights, even when slavery was abolished, or that had an imaginary line drawn in the sand that separated them from the territory their ancestors roamed for thousands of years before Europeans arrived. Truly, there's a substantial amount of history that is excluded because it doesn't match the narrative of America being the greatest country in the world. You can see how this contributes to the continuance of some slightly less obvious but very similar injustices, like our rates of incarceration of minorities, disproportionate occurrence of homelessness for minorities, and increased risk of injury and death for minorities. People who don't experience those injustices or people who do experience those injustices are harmed by them, and I see that every day. What we're learning is that this kind of trauma doesn't just affect people's emotional health. It is very likely a major contributing factor in the development of conditions like diabetes and heart disease. What I see way too much of is people who are emotionally and physically unwell, but that both sets of ailments develop from the same source. As a Lakota woman, my traditional beliefs tell me that it is obvious that to heal the whole person, you have to ensure that all aspects of who they are must be treated. They need healing emotionally, spiritually, and physically. I feel it is very important to empower people to take ownership of their narrative. There's a lot of reluctance to face trauma because people often think it identifies them as a victim, and they don't want to be a victim. No one does. But it can feel really validating to hear that you're not some crybaby because you have felt like the way you've been treated, singled out, etc., is something that has had this tremendous effect on you, and that you've never understood why those things happened to you and not other people. In my experience, both personally, as someone who has had the challenge of overcoming post-traumatic stress disorder with alcohol use, and as a professional working with people who have substantially more exposure to trauma than the general population, there's a need for people to come to the realization that you just don't have the same opportunities or advantages that other people may have. That part can hurt more than even the events of their life, because there's this realization that other people had more and achieved more, but feel that you should be content with what you have rather than having an expectation to be offered the same opportunities. I like to make sure that patients know that they absolutely should demand more and settle for nothing less than their wildest dreams. Ensuring that people know that they deserve equity in all aspects of their lives and is often the first part of healing for people who have experienced the reverse up to that point. Like I mentioned before, I also make sure that my patients' health needs are addressed. We have a case manager I refer to often to help getting people in with a primary care provider. I do screening labs to see if people are experiencing a health problem like thyroid disease or diabetes that might be exacerbating their emotional illness. And I encourage them to seek out things that bring them joy. If they love to paint, let's find a way for them to get some art supplies. If they want to go to the gym, let's try to get them a discount on a YMCA membership. People deserve those opportunities for happiness. Healthy mind, healthy body, healthy spirit, happy person. I want to say thank you for the opportunity to be included in today's panel discussion, and a big thank you to the organizers of today's discussion. It's really important that we have these spaces and this time for these important discussions on topics that certainly affect people's health care.
Thank you, Whitney, for the wisdom and the strength you provide. May this information enlighten all of us on the work we need to do to achieve health equity. So now let's bring in Cheryl Taylor. Dr. Taylor, can you please share with us about your experience in academia and as a public health nurse, especially about racism in nursing education and/or healthcare, and how the social determinants of health are important factors for nurses to incorporate when supporting individuals, families, and communities?
Wow, that's a lot, and I'm going to do my best. But first, let me just say thank you and how grateful I am to the Campaign for Action, to the AARP, to the Diversity and Inclusion, and to everyone that has really helped to bring this conversation forward. I'm looking forward to this, and I'm really grateful to be a part of it. So let me just start out by sharing a jingle that I learned in elementary school. If you're Black, get back. If you're brown, you can stick around. If you're yellow, you're kind of mellow. But if you're white, you're all right. And so that sums up my lived experience in terms of a view that I learned in a jingle in elementary school. And I don't believe that, but there are people that do. And as a result, we have racism in nursing really just simply mirrors racism in society. Nursing mirrors society. So from the whole notion that Black girls and brown girls and Black boys and men should go to be counseled to get a certified nursing assistant and an LPN, and then the few that can that are worthy should go on and pursue their RN, from that idea to the other extreme where there's only a room for a few, one, two, or a few at the top. And then that one, two, or a few Black and brown people or people of color are tasked to do everything. That whole notion is playing itself out in how we navigate in society as African Americans and others dealing with white supremacy and racism. So I want to make it short by saying, since I had to grow up in a racist society and I still witness this on a daily basis, I've always asked my students that I teach to become familiar with 3 films. One, Gone with the Wind, another, Courage Under Fire with Denzel Washington, and another film, The Help. I think the roles and the stories in those films play out what we deal with on a daily basis. But I have some personal examples. As a student nurse at Dillard, which is an HBCU, I learned that the program was 5 years instead of 4 years when it first started because of segregation in New Orleans, in the New Orleans hospitals. And so students had to go outside of the state to have their clinical experiences. Fortunately, we had a dean named Rita Miller from Boston who came up with this brilliant idea. She hired Shirley Smoyak, a white woman from New Jersey, and she had Shirley Smoyak to go around and negotiate all of the clinical contracts for students to have their clinical experiences in the local hospitals. Shirley did that, and the contracts that she negotiated, those administrators assumed because she was white that the students would be white. And the contracts were signed, so when the students showed up, they were told, no, we don't take Black students. And Shirley said, well, the contracts are signed. And so that was the opening of the door. But you can imagine as a student, me learning that from my instructors helped me to appreciate, not to take for granted, the opportunities that we had in the clinical setting. As a young RN, I was told by my supervisor, an afro carries germs. You got to get rid of the afro. I've been called the N-word. I've been called chocolate bonbon by the patients. I've been called coconut breast, all of these things. And of course, I've been asked to go and get the registered nurse, as if I couldn't possibly be the registered nurse. And then when I was the registered nurse, I was asked, well, go and get the supervisor. And then when I was the supervisor, go and get the director of nursing. And so this is just a part of what's happening in society as a whole. At one predominantly white university where I taught, I was recruited there by the dean to be a visible presence for, hopefully, the Black students were being admitted, but then they weren't graduating. So she said, I want you to guest lecture in the students class, in those classes, sophomore students classes. And then also I was scholar in residence at the university, living in the dormitory. So I had that role. I had a Bible study going on, and I had African-American students coming to Bible study once a week. I was wearing a lot of different hats. And I was shocked to be called in by senior faculty and accused of helping Black students. As long as I worked in academia, I've never been accused of helping white students. I help all students. But in this situation, it was like, it's been reported to me that you're helping the Black students. And little did she know that the dean had asked me, that was part of the one of the reasons she wanted me to be highly visible, was because she felt like that would be an inspiration for the Black students. But I wasn't doing any more for them than I was doing for the others. The difference was they felt me and they felt my enthusiasm and they saw the possibility. At that same university, the late Mary Harper, who was an amazing trailblazer in nursing and mental health and healthcare, but she had come long before me. She was one of my early mentors. She invited, she was living in Alabama, in the city at that time. So I invited her to come to the faculty dining areas, a very exclusive place on campus for faculty dining. So I was so proud of myself and my role, and I wanted to make her proud. And so I went to pick her up. She was elderly, in her 80s, and I pulled up on the side in the handicapped area so we could go in the short way through the side door. And when I got out of the car and I started heading in that direction, she said, "How dare you? How dare you, considering all that our people have gone through and how hard we fought and the blood that's been shed for us to have an opportunity to go through the front door. How dare you go through the side door?" So that was a wake-up call for me. She said, "As long as it will take for me to get up the steps and through the front door, that's the door we will enter." And that stays with me because I realize that there's so many things that we take for granted in the opportunities that we have. And so while I realize, yes, systematic racism exists, I may not get through the day without having an experience. I also realize the sacrifices that were made for us to get this far, and I'm willing to work with others, no matter who they are, to make things better. And that's what one of the things that is a part of my mission as an African American nurse, PhD RN.
Thank you, Dr. Taylor, and thank you to all the panelists for joining me today. I will now turn it over to Dr. Lisa Martin and Dr. Winfred Quinn.
Wow, that was very powerful, Lisa.
Yes,
So, go ahead.
Gripping examples today of nurses' experiences in actual practice. And I'm just so appreciative of our panelists and sharing of these stories.
Yes, indeed. Very much so. And so to the audience that has been joining us for the last two sessions, two forums, they know, and we know, that this is normally a time where you and I would discuss a lot of points that came up, and we can do that in our next break. But we wanted to further honor Dr. Bernadine Lacey in Susan and Sue's welcoming remarks. Those were pre-taped early last week, and as the audience and we all know, very sadly, on Friday, Dr. Lacey passed away. And so I would like to invite you, Dr. Martin, if you could share a prayer from the Native American community in honor of Dr. Lacey, and then if we could have a few seconds of silence in her honor.
Thank you, Wynn. I would like to offer this prayer for our colleague and legend, Bernadine Lacey. Heavenly Father, Great Spirit, Thank you for the life of our colleague, Bernardine Lacey, who was with us for so short a while. She worked tirelessly to create a greater presence of culture, health, and healing in our world. We'll continue to follow her examples in striving to achieve health for all. Today, send to our community peace and comfort as we remember her amazing life. Amen.
Thank you so much, Lisa, and thank you to Barbara Nichols and to you for planning for the prayer and honoring Dr. Lacey as such. So, so Lisa, how about if we move on and you bring on our second panel?
That sounds good, Wynn. I'm also excited to hear from another group of nursing leaders. We have two current members of the Campaign for Action's Equity, Diversity, and Inclusion Steering Committee, Dr. Mary Joy Garcia-Dia and Mr. Blake Smith. Mary Joy is the president of the Philippine Nurses Association of America, and Blake is the president of the American Association for Men in Nursing. They are joined by Dr. Jasmine Travers, a long-term care and disparities expert who is on faculty at New York University's Rory Myers College of Nursing, and Sheldon Fields, Associate Dean for Equity and Inclusion and Research Professor, College of Nursing, Penn State. This panel is being moderated by someone I have come to know over the past few years in her role as the co-chair of the Campaign for Action's Equity, Diversity, and Inclusion Steering Committee, Dr. Carmen Alvarez. Dr. Alvarez also wears other hats. She is on faculty at Johns Hopkins University Department of Community Health and is a practicing nurse practitioner. I am now happy to introduce Dr. Alvarez. Carmen?
Thank you, Lisa. It has been great to get to know you over the past several years. It has been an honor and wonderful experience co-chairing the Equity, Diversity, and Inclusion Steering Committee. It has been wonderful to work with nurse leaders like yourself and all who represent Nana Aina, the National Black Nurses Association, the National Association of Hispanic Nurses, the Philippine Nurses Association of America, the Asian Pacific Islander Nursing Association, the Umbrella Group and SEMNA, and the American Association of Men in Nursing. It has been great to work with Sue Hassmiller, Susan Reinhardt, Scott Tanaka, Jasmine Cooper, and Wynn. COVID-19 has exposed the need to accelerate change in healthcare, especially for achieving health equity. I wish to thank this committee for their foresight, agility, and adaptability for accelerating our own mission and vision so that the nursing profession can keep pace with the rate of change. I am now very happy to hear from our panelists. I will start with Dr. Garcia-Dia. Mary Joy, it was a year ago at this time that the big wave of COVID-19 was impacting New York City and the northern New Jersey area and other hotspots throughout the nation. Many of your members are based in New York City and the northern New Jersey area. And while this was a hard time for the entire nation, it was especially hard on Philippine nurses in the United States, particularly in the Northeast. What can you share with us about how COVID impacted Philippine nurses working here in the U.S.?
Thank you so much, Carmen. As we reflect the solemn one-year anniversary of the first COVID-19 case in New York and the staggering death toll of healthcare workers due to the pandemic, I hope we can find some reason and understanding through our personal and professional advocacy. On my first slide, based on the analysis from the Kaiser Health News and The Guardian on loss on the front lines, the number of deaths of healthcare workers total over 3,000, and 33% are nurses. The statistics on this slide provides an overview of deaths by state, by ethnicity, and by country of origin. New York is the state that have lost the most healthcare workers, which was the epicenter of the pandemic, totaling to 431. Out of these deaths, 22% of the population are from Asian Pacific Islander based on race and ethnicity. However, more than a third were born outside of the United States, accounting for 105 deaths from the Philippines. Up to this time, our organization continues to struggle in understanding the data as there is no comprehensive record and data disaggregation of Asian Pacific Islander. What I can tell you is that this pandemic has hit our organization up close and personal. If you recall, I remember holding my tears back while I was providing an update to the Equity, Diversity, and Inclusion Steering Committee way back in April 21st, sharing with everyone how PNAA was impacted by the surge of COVID-19 cases. At the time, Madeline Yu, who was the PNAA president, has been hospitalized a week after her husband was admitted because of COVID-19. Little did I know during that day that Madeline's husband will lose his fight with COVID-19, leaving Madeline with her 3 children and grandchildren. These similar stories of our members losing their spouses and reports from chapters that 3 or 5 members got sick of COVID became a recurring story as I stepped in as president in July of 2020. Similar to our nursing colleagues from NBNA, NAHN, AAPINA, and NANAINA, Filipinos belong to multi-generational family of nurses and healthcare workers. As I gather reports from our 55 chapters in 43 states, I continue to hear the same stories where 2 to 3 of our members' family are dying weeks apart, and majority do not have time to grieve as they continue to work in the front line. One of our past presidents, Zeni Lipat, lost 2 of her brothers, one in Long Island and the other in New Jersey, while she herself is in the nursing home sick with COVID-19. I lost my uncle in Hawaii in December of 2023, and my aunt has to delay his funeral service as she herself is in the hospital. Our PNAA executive director lost her mother-in-law, while 6 members of the family were sick and 2 passed away in less than 40 days. These stories are heartbreaking and will continue to haunt our members and our community. However, we know that we need to recover. On my next slide, since March 7, 2020, PNAA have provided weekly updates to our members through our COVID-19 task force, where I launched our Heal Our Nurses campaign, aimed to first reflect on what's going on, second, to reset where we are and refocus, and third, to recover and address what's the future for nursing. As a member of INSIMNA, we contributed to peer-reviewed articles on providing culturally congruent care and issued position statements on addressing counseling programs for our frontline workers. I remember that one of our local PNA New York board members simply said, "Our focus right now is just trying to survive." And that was during the height of the pandemic. Through our legislation committee, we have sent letter of appeals to state legislators in streamlining policies on structural issues with personal protective equipment and access to COVID-19 testings as the guidelines constantly change. Because of our culture, spirituality is up in everyone's mind. We provided counseling programs, and recently, because of the emotions behind the mass survey that we have, our practice committee is launching the Kabalikat program, which cater to our Filipino traits of kapwa, or the Mayan, or the collective nature of helping each other. This program will be implemented as we know that we need to recover and focus for the long haul. We know that health disparities pre-COVID existed, but with the rise in anti-Asian sentiments, plus the ongoing psychosocial and emotional impact of COVID-19, PNAA have kicked off an oral history project under our archives committee in collaboration with the Justly Project. This is to honor not only the many lives lost during COVID-19, but also to remember the resilience of our nurses who will always have a story about what happened during the year of the nurse and what are the most important lessons that they learned and who are the people and the work that they are most proud of. So thank you, Carmen, for letting me share PNAA story.
Mary Joy, thank you so much for giving us these insights. It was difficult and very hard to hear these stories last year as they were occurring. The larger picture you've provided is just overwhelming, and I'm very happy. I think the Philippine Nurses Association of America is very lucky to have you as a leader leading the recovery and the way forward for the organization. So thank you for all you do. Turning to men in nursing, at the same time we were hearing from Mary Joy last year, Blake was sharing with us about the struggles of the many men in nursing who were on the front lines. Blake, tell us about your organization's approach to addressing these issues.
Well, thank you, Carmen. As we understand as nurses, we have always tended to put others' health and well-being before our own, even prior to this last year. The difference the pandemic has presented, though, is that prior to this last year, many of us had the capacity to sustain the stress that comes with our profession, but the surge of need and volume had tipped us over the edge in so many instances. Many of us have had to be told to slow down, take care of ourselves, participate in self-care. And what is our response? When? How? And though the tools were provided to us, they were shown to us, we all know that it was still difficult to find those areas and the time to participate in that self-care. While the stress is shared across the entire profession, depending on our own life experiences, we deal with it in different ways. I personally found myself in a position as someone who has only left the bedside in the last 3 years. And I had this feeling of needing to do something. And in my current role, I found myself impacting from afar and not in the trenches with my colleagues. After discussing with others who I trusted in the mental health specialty, they defined my thoughts as a type of survivor's guilt. And that term really helped me process my thoughts and turn them into purpose and action. I decided that in my position, the best way I could impact the bedside is to make sure I was directly supporting my colleagues and especially the men in our profession. Because as you may or may not know, men tend to not share their feelings well or practice the best ways of de-stressing. Men in the nursing profession are not an exception to this trend. Based on our historical society norms, we as men have been taught for what seems like the beginning of time to not show vulnerability or emotion. We are hardwired to be looked at as the so-called rock, being in control at all times, leaving us to deal with our emotions and our vulnerabilities internally. So when reflecting on what I could do to positively support the men in our profession, I knew that if they did not have someone to confide in who could relate to their situation, it would potentially lead to one of two results. Anger outbursts at work or home, as men tend to funnel into one form of release of feelings, though that anger may not actually be the core, or over time internalizing emotions to the point of depression, and in some of the worst cases, potential suicide. So I started to do well checks with the members of AMN. As president, I just took the member database and started reaching out. I used multiple means such as email and text to make contact, which then led to phone calls where I filled the role that they needed me to fill at that time. Whether it was advice from my experience in critical care, leadership decision-making, or most importantly, just being an active listener. I wanted to provide a safe environment for them to vent or relieve the building stress that they had within. By taking this approach, it was not only provided the ability for the men in our profession to have a safe space to share their thoughts, And I use the word thoughts as men have a stigma towards the word feelings and unconsciously shut down from that word. But it also helped me process my own thoughts that my closest mental health colleagues defined as a form of survivor's guilt. I do not believe this is something that is at all limited to the traditional male identity in our profession. This could happen with anyone based on our own personality and should not be assumed based on a binary view. We have colleagues that identify across the spectrum of the gender identity. And I would urge all of us who may not be able to be on the front lines to do well checks with our current colleagues and students, who I like to refer to as future colleagues who are in the pre-licensure programs, because they're just as stressed as us, who are currently practicing and trying to finish schooling and preparing to enter at an unprecedented time. We must not only look out for ourselves on our own, but the accountability to do self-care will have a better chance of sustainability if we help look out for one another. I will end with this. For our female colleagues watching today, if you see one of your team members who happens to be a male team member begin to withdraw, have a change in personality over the last year, or experience irritability or outbursts, it may be a result of having unhealthy means of working through the difficulties of this past year. We cannot walk this journey alone. And for all the men watching today, now is not the time to be a hero. You must be able to share your thoughts with your colleagues. And you can reach out if you have no one else. Call myself or call a member of AMN anytime, because we're here for you to confide in. So thank you for this time, Carmen, for letting myself speak on behalf of all of the great men in our profession. And I look forward to the rest of the panel.
Thank you so much for that, Blake. Your compassion and service for men in nursing, particularly with their mental health, is so important and will undoubtedly have great impact. And thank you so much for those helpful tips towards the end. Now we're turning to Dr. Jasmine Travers, a nurse scientist at NYU, who is a long-term care and disparities expert. Jasmine, I understand that you have a personal story that you would like to share and how it inspires you in your work. So please tell us that story, and also about the disparities you are aware of in terms of long-term care and testing, vaccines, and also resources you would like to inform us about.
Sure. Thank you. Thank you, Carmen, for having me and allowing me to share a little bit about what keeps me, really aiming to improve the care in long-term care and then also the workforce. So my mother, like myself, is a nurse, and she provides adult foster care in the home. Last year, one of her biggest fears was that those people that she provides care for were going to get COVID. Everyone inside the house was 65 years of age and older. In addition, my uncle lives with my mother. My uncle is a nursing assistant working in a nursing home. So that is what drove one of her biggest fears. And he also takes public transportation to the nursing home every day through a bus. One day, my mother called me and she said, the inevitable has happened. Your uncle has tested positive for COVID, and you could hear the emptiness in her throat. And I tried to keep it together for her. And I told her, it's okay. We just need to quarantine him, get him out the house. She said, can you help with that? And I said, sure. And I was thinking about all of the resources that were available for healthcare workers to quarantine within hotels and other resources and supports. So I began to call hotels in the area. Many said they didn't provide stays for long-term care workers. And then I did stumble upon a hotel that said, yes, we provide free stays 100% for nurses and physicians. But then for long-term care workers, specifically nursing assistants, there's a modified rate. They had to transfer me to another line to get that modified rate. Once I got to the other line, they told me that modified rate was $100 a night. My uncle needed 14 days to quarantine at that time. That equated to $1,400 for the 2 weeks. At that point in time, I started to swell up in tears. It didn't make sense to me, the system that we lived in. How were nurses and physicians who made far more than nursing assistants receiving free stays at hotels, while nursing assistants who make a median of $13 an hour, $22,000 a year, where my uncle's salary would not even cover a 2-week stay, and that doesn't even cover the taxes and the fees that end up doubling that stay. For me, it was okay because I could cover the cost, but then I thought about all of the other nursing assistants who did not have family members who could cover the cost so that they could safely quarantine away from their family. There are nearly 600,000 nursing assistants working in nursing homes across the U.S. They make up the largest proportion of the nursing home workforce at 36%, followed by licensed practical and licensed vocational nurses at just 13%, and registered nurses at 9%. Nursing assistants are also the largest proportion of the nursing workforce in nursing homes, and most significantly, they spend the majority of time with nursing home residents. Yet 13% live below the federal poverty line. Nearly half live in low-income households. A third rely on some form of public assistance, and a tenth are without insurance. Prior to being deemed one of the most dangerous jobs in America during the pandemic, nursing assistants have been found to be injured more than 3 times more frequently than the typical American worker. My uncle represents a workforce that is undervalued, underpaid, and poorly treated. When we look to understand why staffing is such a problem in nursing homes, which has led to disproportionate COVID-19 infections and deaths most recently, and is historically associated with quality of care, we must look at the structures in place that have birthed these issues. Nursing assistants and registered nurses get paid far less working in nursing home settings compared to acute care settings. And while changing, nursing schools very commonly prepare our students for careers in acute care settings, neglecting the need to promote careers in long-term care settings, which both drives a preference towards hospital employment and thereby makes it difficult for nursing homes to attract and retain enough workers to fully staff all shifts. Our society minimally regards the care of older adults as of high importance. Oftentimes, it's not until we ourselves are in roles of caregiving do we begin to recognize the insurmountable gaps in our healthcare system. Staff lack the resources and supports to do the work that they are charged to do. Not only were nursing homes without PPE, like many other healthcare systems, but they were without the infrastructure to adapt and respond to the needs of their residents with similar resilience as acute care settings. This includes technology, nurse educators, and clinical nurse specialists, and regularly on-site infection preventionists. We talk more about vaccine hesitancy and less about the changes needed to right the wrongs that fuel a portion of the hesitancy, such as showing respect to nursing assistants and including them at the table when it comes to decision-making. Medicaid payment is lacking. For-profit nursing homes are permitted to choose where they allocate their funds, which often comes at the expense of staffing and resident quality care, and are where more residents of color reside. Current regulatory efforts are not doing the job that they are tasked to do. For example, staffing remains insufficient. Infection control deficiencies are longstanding problems, and disaster response always seems to be futile at times of disasters. And all because regulatory has always been a system to game as opposed to a feat to master when it comes to placing a focus on improving quality rather than ratings alone. So what are we left with? What has the pandemic shown us? Segregated nursing homes, those with the highest share of Black residents do worse when compared to those with a low share of Black residents. Residents in general receive less than optimal care, and racial ethnic disparities and pressure ulcers, restraints, and vaccinations, to name a few, are salient. And the nursing home workforce is beyond stressed and burnt out. Mean turnover for nursing assistants are 129%, registered nurses even greater at 140%. Nursing homes will need to fill nearly 680,000 nursing assistant job openings alone between now and 2026. But how? My uncle is one of the several nursing assistants that has left the nursing home workforce since last year because of fair and insensitive supervision that told him he needed to come into work the next day right after receiving his diagnosis of COVID. When this workforce is depleted, who will take care of our most vulnerable population? That is our fathers, mothers, uncles, aunts, brothers, sisters, friends, neighbors, us. We need to take better care of our long-term care workforce so that they can take better care of our loved ones. And then we need to thoughtfully hold those in positions of authority responsible for how this care is carried out. We need to change our language when we talk about aging, older adults, and long-term care to begin to remove the stigma associated with these groups and settings. We need to reach the community, nursing home setting, hospital, and academia so that we can pull our resources together to advance better care for all. And we need to equip our staff with adequate training, pay, benefits, resources, support, and recognition for the tremendous work that they do. We need to do this now. Thank you, Carmen, for allowing me to share. And I look forward to the rest of the panel.
Yeah, you've left me quite speechless, Jasmine. Thank you so much for shedding light on this part of our workforce that, yes, you are right, has not received their due attention like many other auxiliary workers within our profession that really hold us up and are a critical part of the work that we do, whether it's inpatient or outpatient. So thank you for shining the light on them. We will wrap up our panel by hearing from Dr. Sheldon Fields. Sheldon, before asking you to speak with us, Winifred Quinn asked me to thank you. She said that you were someone who inspired her 10 plus years ago with the original Future of Nursing report when that report was released. And during the report's press release, you informed the IOM committee that you were disappointed that the report didn't specify diversity and inclusion in nursing. Therefore, Win and the campaign leadership want you to know that you were heard. And within the first year or so of the campaign, they launched what is now the Equity, Diversity, and Inclusion Steering Committee and began our work on diversity and inclusion in nursing. So thank you for your inspiration and motivation. We know this passion is still alive and well, and we would love to hear your thoughts about academia's role in eliminating disparities in healthcare. So what experiences have you had that provided you with the wisdom that you have?
So first of all, thanks again, Carmen, and my colleagues. Your stories are really inspirational at this point. I remember that day when, as well, I was a Robert Wood Johnson Health Policy Fellow at the time, and I very much indeed asked that question at that panel. There's a recording somewhere to prove that. But in terms of where we are in how academia can address these issues, and I've been an academic for 30 years, and I knew then and I know now, and I'm going to talk specifically to nursing and my nursing colleagues. First and foremost, within academic nursing, if academic nursing is serious about addressing health disparities and all that it comes with, academic nursing must first join other health disciplines in doing things such as declaring racism to be a public health crisis. And why do I go to the issue of racism, Carmen? Because nursing, being the largest of the healthcare professions and the most trusted, has a responsibility to society to prepare a healthcare workforce that is truly going to serve and be able to truly take care of everyone in our growing, diverse society. That is our sacred, it's embedded in our ethical code. And we don't get to choose who our patients are, but we do get to choose who we admit to nursing school. And let's be very clear, at 90% female and 80% white, the nursing profession is not diverse. And nursing doesn't want to talk about this because they see it as impolite or it makes people uncomfortable. So let's start at the beginning with admissions. Admissions to nursing school must be holistic. In this way, we get away from the myth of a zero-sum game, which means that if we admit more minorities, that we somehow are going to admit less Caucasians. And that's not it, because, the health profession's gain is not your loss. We need to look at that very differently. And because if we address these issues and we start to think about the curriculum, so let's think about those students once they're admitted. Academia has to do a much better job of teaching the entirety of our history in nursing, not just a white perspective that starts and ends with the accomplishments of people like Florence Nightingale while not talking about people like Mary Seacole. When we talk about advancing in nursing education, think about all of the work that can be done if we structure curricula for those masters and DNP students doing quality health projects or other types of health improvement projects. If we focus those works on needing to address the myriad of health disparity health issues. Pick a topic, come up with a solution. No one is more creative about coming up with healthcare solutions than we are in nursing. So imagine the amount of work that we can start to begin to do and address if we focused our students in that way. At the doctoral level, when we talk about training the next generation of nurse scientists, I think that we need to incorporate into all of that curriculum elements of critical race theory into the very structure of how we are teaching those students to think about ways that come up with those research solutions and those research projects. Because critical race theory talks about addressing health inequities, and really gives us a framework to do so. When it talks about nursing academia and faculty, we need to be very serious about how do we diversify the nursing faculty. There's a lot of us who went to nursing school who never saw a reflection of ourselves throughout nursing school. I never had a Black male nursing professor. Never. Still to this, I mean, it just astounds me that I never saw someone step in front of a classroom that mirrored me. Now, why is that important? Because, many people believe you can't become that which you do not see. You cannot get the type of encouragement in an environment that keeps telling you that, you don't necessarily matter. When it comes to the staff that we hire, a lot of nursing schools don't pay much attention, and academia don't pay enough attention to the staff that they hire. And our diverse and multicultural students that wind up in our programs are dealing with staff that are hostile towards them. And, they don't, where do you turn to when the admin of your program is not responsive to you or, is not necessarily even aware of what your needs are? So, academia has a long way to go if we are to truly address these issues. And we need to start talking more and more. And I'm very serious at this point. My entire career at this point has culminated in what I do, particularly in my new role at Penn State as the inaugural Associate Dean for Equity and Inclusion. And adding positions such as mine to schools and colleges of nursing is the right way to go. And there are several schools and colleges that have begun to do so and really bring in a level of expertise that really will begin to help move that needle. Because, one thing that we saw with the pandemic is we've all been dealing with multiple pandemics at the same time. So you had the pandemic of COVID-19. You had the pandemic of an ongoing issue of racism. And we need to name it like that. Those issues of racism in this country have long been here. They didn't just start neither. But they blew up last summer, when we, unfortunately, as we all witnessed the death of George Floyd, that sparked mass protest across our country. Nursing, still had to go to work, and nurses, and particularly nurses of color. Think about this. Those nurses of color, those faculty had to deal with both that issue of racism and still do their jobs as frontline workers and faculty, moving from the classroom to online and everything that came with that. But I am a bit of an optimist, and I believe we have a very unique opportunity. And I choose to look at it this way, to get it right. And we need to start having some conversations that are more often and more frequent, that push people's particular boundaries to address the barriers to achieving, health equity. Because, when we will not come to any type of progress until we achieve health equity. And health disparities will disappear or will be eliminated when we do achieve health equity. So they're one and the same. And we have to get real about preparing that next generation. As one of my colleagues stated, we're going to have to replace quite a few nurses, and they're going to have to come through our academic and educational systems to do so. And I think we have a great opportunity to get it right this time. So thank you for the opportunity and the platform. I'm really honored to be here with such esteemed colleagues.
Well, thank you so much, Dr. Fields, and to all of our panelists. You have provided very powerful and poignant insights and stories. Thank you for elevating the voices of the marginalized among us. I know the campaign will use these stories and lessons in our continued efforts for achieving health equity. So thank you. Back to you, Lisa.
So, wow. I mean, the presentations that we're hearing today are very important stories to be shared and facts to be shared and experiences to be shared. I am not a nurse, but I obviously am somebody who's committed to helping to diversify and have nursing be more diverse and inclusive. And we at the Center and the Campaign for Action are dedicated to that. There's quite a bit of chat as well in the chat box. And so, Lisa, I'll bring up a couple of points that were made, and then maybe we can engage some of the questions that are coming up. So one specific question that was asked was by Connie Bishop, and it was, how many predominantly white institution schools of nursing have a dean or a chair who represents Black, Indigenous, or other people of color? And so we at the campaign don't collect those data, but in preparation for our initial Health Equity Forum in January, we reached out to our friends and colleagues at AACN to ask them if they had, if they could share with us their data on race and ethnicity demographics among faculty, as well as directors or chairs. And so, unfortunately, the numbers are stark. Just under 10% of the nursing faculty is comprised of people of color, and among chairs and directors, the administration level, it's about 4%. And that's, listen, and so Connie, I know you asked specifically about PWIs, but this is for all nursing schools from BSN and above. So we would have to find out if AACN or if others collect PWI specific data like that. So I hope that helps answer that question. Although obviously I wish that it could have been more positive information to share, but we're at a point where a lot more needs to be done to help increase diversity and inclusion in nursing, and that's why we're having these forums and asking people to bring forth the very real experiences of nurses and nursing faculty and others in the nursing profession who are experiencing the downside of society, really, in terms of racism and injustice. And what we hope to do is to turn those around. We need to create health equity, and one of the ways to do that is through a more diverse and inclusive nursing nursing sector at all levels. So anyway, Lisa, what are your thoughts?
Oh, thank you, Wynn, for addressing the question, and to our organizers for this event. I think, like Dr. Fields, I am an optimist as well. We have a lot of work to do, as you've said, but when we understand the reality that we're in, we can begin to design new approaches to achieve our goals. I believe that strongly. I'm so impacted by the panelists' presentations today, and I wanted to share just a few thoughts. It sounds to me very much that we are recovering from the previous year. We're in a state of recovery, and to help us move forward through that recovery it'll be important to find our source of resiliency and reconnect with our relationships. Also, what Blake mentioned is it's important to fit into roles that are needed at this time. Also, a part of recovering and finding a better reality as nurses for our patients, clients, and our communities. So those thoughts came to mind.
Oh, Lisa, thank you so much. So listen, I was getting a message in my ear while you were making those summary points. And so it is actually time for us to move on. We're about to hear an incredible conversation with two amazing nurses led by Edna Kane Williams. So Lisa, I'm going to hand the microphone back to you so that you could bring on our next trio.
Yes, Wynn, that sounds good. And thank you for joining me today in our conversations. Now, I am honored and pleased to introduce Ms. Edna Kane Williams, Executive Vice President and Chief Diversity Officer of AARP, to facilitate a dialogue with two amazing legends in nursing. This conversation will wrap up our 3 health equity action forums. And it is not by chance that we are closing with Edna, Barbara Nichols, and Bev Warren. Edna is an instrumental nurse champion at AARP, especially when it comes to eliminating disparities and achieving health equity. Barbara Nichols is a living legend within the American Academy of Nursing and is the ANA's first African American president. We at the campaign are also so honored to work with her in her consulting role to CCNA. Finally, we have an elder and legend within the Native American nursing community, Bev Warren. I have learned so much over the years from Bev, and I'm also so inspired by the wisdom and the truth that she offers us. Now, I am ready to ask Ms. Edna Kane Williams to facilitate this conversation with our two wonderful legends, Barbara Nichols and Bev Warren. Edna?
Well, good afternoon, everyone, and thank you for joining us for this final session of this wonderful Health Equity Action Forum. We've had an incredible array of speakers and participants, and I'm really looking forward to this session. I first want to thank Dr. Martin for her role as MC and for introducing me. And I will say again that I'm Edna Kane Williams. I'm Executive Vice President and Chief Diversity Officer for AARP. If I stumble over that title a little bit, I was just promoted last week, so I'm still pinching myself, but I'm really delighted and just so excited. And I'm excited to be here also. I also want to thank before we get into the meat of this session, I want to thank the conveners and 3 people who have really been essential to the delivery of this forum. First, Dr. Winifred Quinn, Scott Tanaka, and Jasmine Cooper have been working tirelessly behind the scenes to make sure that we all had a great experience. And it's been a wonderful forum, and I just personally want to thank them for all of their hard work. Now, it's Women's History Month, and there's nothing more fitting than to celebrate and lift up hidden figures in the nursing arena. And we have 2 very excellent presenters this afternoon to help us talk about some hidden figures, their roles, their contributions, and just making sure during this Women's History Month that we broaden the stage, that we make sure that we're including and talking about all of the different people who have brought us to where we are today, and really that we're standing on the shoulders of. So first, I want to thank Barbara Nichols for joining us. Barbara is an expert on, now I said I was going to say Dr. Nichols. I apologize, Dr. Barbara Nichols, and you'll see in a moment why. She is an expert on global nursing execution, practice, and leadership. She's the only person I know that has 5 honorary doctorates. She's worked at the state, national, and international levels, and I can't wait to hear from her. I'm also delighted to welcome Bev Warner, who has 58 years of work experience, including working with hospitals, both in the public, private, and military settings. She's worked in home health, in school health, outpatient clinics, international service, including Bangkok and Thailand, and public health nursing with the Indian Health Service. So welcome to you both. I'm so glad that you're here. I know that our audience is anxious to hear you talk about some hidden figures and your experiences with them. This month is all about elevating our women heroes, sheroes, who've helped us get to where we are, and really their experiences, their lessons learned will help us move forward with success. So first I want to start with Dr. Nichols and ask a question of you. And my first question is, often people know about Florence Nightingale, but please share about nurses of color who have also had a significant impact in the history of nursing in this country.
Well, the one hidden figure I would like to present at this time is Mary Seacles. Mary was born of an interracial couple in Kingston, Jamaica, and went to Britain to apply to work with Florence Nightingale in the Crimea. And she received racial discrimination, was told that she was not qualified, nor was she wanted, nor at any time would they make a position available to her. Being refused, however, didn't stop Mary. Mary said, I will go independently. And so Mary went to the Crimea on her own. Mm-hmm. She worked with Florence, but more importantly, she established a hotel, and this hotel was used where soldiers from Sakari would come for convalescence. And Mary was famous because her mother in Jamaica had been known as a doctress, and a doctress in colonial times meant that you were an expert at using herbs and other medicinal potions to correct and heal and help people to be healthy. And so Mary used her knowledge to help heal and provide care to the soldiers during the Crimean War. She's frequently not mentioned. She didn't work directly with Florence. She did work aside Florence, and she was there. The other thing that's interesting about Mary, her parents were interracial, and Mary married a white general who was the great nephew of Nelson, who defeated Napoleon at Waterloo. And when he died, she never remarried. She was an independent spirit, had a lot of grit, was exceptionally knowledgeable, and no one told Mary what to do. Mary decided, this is me, this is my truth, this is my expertise, and I will go independently because I'm needed. So she's a hidden figure that really isn't discussed in terms of the criteria. However, in London at St. Thomas, which is the hospital that Florence Nightingale founded, there is a wonderful statue of Mary Seacles in front of the hospital. And so if you get to London, which I've had the opportunity and the pleasure to do, when you visit St. Thomas, you also see Mary, and they do describe her contributions.
It was seeing the statue the first you learned of her, or did you know of her before you saw the statue?
As an American nurse, I really didn't know about Mary Seacles. I thought I was doing good knowing about Mary Mahoney, but I didn't know anything about Mary Seacles. So I was really surprised, and the energy that British nurses have in terms of embracing her and telling her story. They seem to be much more engaged than American nurses are as telling Mary Seacles' story as compared to American nurses, regardless of color, telling Mary Mahoney's story. So I thought that was interesting because of my role as a chief executive officer dealing with migrant nurses. The UK is known as being extraordinarily racist in terms of its acceptance of nurses of color into the UK system, which of course they deny. But the facts are, they are. So,
which makes the fact that there's a statue all the more remarkable, right?
It is absolutely
surprised.
Yeah, it is absolutely remarkable in that regard.
Yes. I want to hear more about Mary Mahoney, but I'm going to go to Bev to ask her to share a hidden figure in the Native American community. And then Dr. Nichols will come back to you to hear more about Mary. Bev?
Thank you so much for a kind introduction. I am Native American from South Dakota, the Lakota tribe. And I worked in Arizona for many years. And when I was in Arizona, we had formed a Native American Nurses Association. And during one of our activities, we wanted to acknowledge Native American nursing in history. And so we found Susie, Walking Bear, Yellowtail. Walking Bear is her maiden name, and Yellowtail was her married name. And she is from the state of Montana. Her mother was Oglala Lakota, and her father was Crow from Montana's tribes. And she was born in 1903 and grew up there. And then she became orphaned early in the preteen years. So she was sent to a boarding school. But eventually she had foster parents who were non-Native, and they traveled around the country being assigned to different areas. And so she did wind up on the East Coast, where she did complete high school and nursing school. She graduated from the Boston City Hospital in Philadelphia in 1927 and worked in India for a few years, and then returned home to Montana to work with her own people. And she worked in a government hospital for a little while and realized there's so many unmet needs of Native people that had health disparities that were unbelievable. And somehow she was able to get a job with the Public Health Service as a person to travel throughout the United States to assess and document healthcare of Native communities. And so this is what she did. She went to the reservations and found challenges that people were living under regarding health. And so she did this from 1930 to 1960. So she had a long career doing this, and she found health issues. For instance, she found the death rate among children because of lack of access to medical care. That was one of the documentations that were found about some very heart-wrenching stories about children. And then she also found out about the sterilization of American Indian women without consent, which was throughout the country in those days. And then she did identify the need for culturally competent health care. There was so much disparity and inequity, and it was based on not understanding each other's culture. And that come out of that, for instance, like communication. She realized the sanitation problems that existed that needed to be tended to, and of course, transportation challenges with people living on reservations far away from healthcare facilities. And she advocated for all of this with her knowledge of health policies. It was just fascinating to read this story because we did not know about her. And of course, I did more research since this assignment for today. And she advocated for allowing traditional tribal healers to tend to American Indian patients. And she must have been one of the first people to advocate for this. Right now, it is happening.
Interesting that we think of these this awareness of disparities and the need for culturally sensitive practices and materials as being sort of a newfound focus, but you're demonstrating that this she was really in the forefront for years in terms of trying to bring this awareness and highlighting this kind of work. That's what's fascinating to me, that we think that cultural competency is a new paradigm, but really she was talking about it 40, 50 years ago.
Yes, exactly. She advocated for higher education for the Native American population, integrated with cultural knowledge of the beliefs and values of Native people, which again, we think of that as a recent phenomenon, but it's been
not. Yeah.
Yes. She also created the community health representative outreach program on the reservations, which is a group of women of the tribe who are trained to do simple assessment things like, for instance, knowing what questions to ask of a diabetic, and knowing questions to ask a mother of a toddler regarding immunizations. And so the community health representatives, we call them CHRs, and I remember working with the CHRs when I worked on a reservation in Arizona, and they were invaluable. They knew the community, they knew the health beliefs of the people, and they knew the families very well, historically and the current families. And so they are a wonderful bridge for public health nurses to connect with the people. And so that's going.
Great. That's really, I'm just struck by how she really is all of the things that we think are new discussions today date back to her work. So thank you so much for bringing more knowledge about her work and her impact to us. I want to turn back to Dr. Nichols. And again, I'm just so energized. When you think about nursing, you don't think about Black and brown women. You don't think they are truly hidden figures. Unfortunately, we really need to unveil the impact that they've had. So I think we've had two excellent examples so far. Dr. Nichols, can you tell us a little bit more about Mary Mahoney? You started to talk about yet another African American women.
Yes,
Who's had.
Yes, I would like to talk about 3 African American women, if I may. Sojourner Truth, Harriet Tubman, and Mary Mahoney. And I would like to add on to the previous speaker's comments that Mary Seacles, actually in 21st century nursing, would be described as a nurse practitioner. The level of care that she provided in the communities in which she worked really made her a primary care provider. So she really was a forerunner for the nurse practitioner movement. What I want to say about Sojourner Truth, Harriet Tubman, and Mary Mahoney is this. Harriet Tubman and Sojourner Truth were born in slavery. Mary was not. But all were around during the Civil War and experienced the tumultuous chaos of Reconstruction. And they saw firsthand the bias, prejudice, and discrimination that occurred on the basis of inequities. And they were each committed in their own way to social justice, racial equality, all within the arena of providing effective and efficient care. Sojourner Truth, I would have loved to have met her. They said she's described as being over 6 feet tall with this booming voice and gave speeches everywhere on the need for women to be treated in equitable ways. So she was an advocate early on for women's rights. And as we know, Harriet Tubman was a slave who created and was successful of getting people through the Underground Railroad. And as she would say, she never lost a passenger in that regard. And as far as Mary was concerned, she worked 30 years before she went into nursing, what we would now call a nursing assistant. And thus they were all committed to social justice and advocating on behalf of nursing. Clara Barton was a contemporary of all of them, and Sojourner Truth and Harriet Tubman also provided care during the Civil War, so they would have been sort of contemporaries of Clara Barton, who founded the American Red Cross. But you never hear Harriet and Sojourner talked about in the same context as Clara Barton. Mary Mahoney's significance is that she created really the National Association of College Graduate Nurses, because when the American Nurses Association was created in 1897, they were sort of reticent and discriminatory about accepting Black licensed nurses. So Mary was instrumental in forming the National Association of College Graduate Nurses. And that entity dissolved at the end of World War II in the spirit of doing away with segregation and discrimination in nursing, with ANA making the commitment that it would continue on to present the Mary Mahoney Award. So they all have sort of interesting histories. What binds them together really is that they all emerged in tumultuous times. They all were pioneers in the face of discrimination and bias and prejudice. But most importantly, from a nursing perspective, they were efficient, effective, and knowledgeable in providing compassionate care. Right. And so it really makes me proud to be able to say a few words in their honor.
Well, thank you. I'm learning so much. I did not appreciate Sojourner Truth and Tubman's role in early nursing practice. So thank you both for educating us. I want to go back to Bev now, because I think now we're going to talk a little bit more in terms of contemporary hidden figures and our role in creating new sheroes. And Bev, I know that you've been very involved in mentoring students at the South Dakota State University's College of Nursing. And I want to ask you about the value of mentoring and your role in mentoring. And do you think that's having an impact in increasing the number of Native American nursing students?
Oh, yes, I truly do. My work at South Dakota State University is the first thing that I need to say is that it is all about mentoring. And I have other titles, but my focus is on the mentoring process because that's what we do with each student. Before our program started, which is a Native American Nursing Education Center, it's a place that was designated for our students, our Native American students. And when you walk into our building, you can tell that it's Native by the decor. And we have a welcoming room, we call it. It's like a living room, very comfortable chairs, a place that is not using fluorescent lights. They're nice, subdued lighting. And we have food in there as well. And then we have an infuser with sage oil infusing into the air. And it's just very calming because sage is one of our healing herbs that we use for many purposes. And we know that. And so we could see it happening when the student walks in and you go into that room for your talk. Their little shoulders are up. You know how you get when you're tense. And then they sit down in a comfortable chair and we offer food and drink. And then, of course, I'm known as Unchi among the students because I am older. I'm an elder. And Unchi means grandmother. And so that's comforting for these students to sit down and that smell of sage oil and this nurse who loves you is sitting in front of you. And is a different kind of an approach for us at our place because the other two people I work with as partners are both Native American. One is a nurse and the other is a higher ed person, but she's quite traditional in her way. She's very grounded in who she is. And so when we do our mentoring, I meet with students once a month, plan. It's an appointment, and it generally takes approximately an hour. But the wonderful thing about mentoring for me as an older nurse is to hear about the student's day, for instance, at class, whatever class it is, they go down the line with each course that they're enrolled in and tell me about what they're learning. And they tell me the teacher. And in the beginning, I always ask them, is your teacher approachable? And sometimes they don't feel that the teacher is approachable. But it's a cultural thing at times because students who are traditional in their thinking and upbringing do not want to question authority, do not want to question a teacher. And so they feel that, but the teacher obviously is not. And so that is just a very small detail that I know happens because I felt the same way when I was a student. And I know the feelings and thoughts that students have, they don't necessarily articulate because maybe they don't understand it themselves. So I've traditional differences, cultural differences as we move along in the mentoring process. And so through each course and the clinical days are exciting for me to hear. And I think they get that feeling of this lady really truly is interested because they talk about robots doing cataract surgery or prostate surgery. It's just fascinating, the world of nursing today and what the students are learning. And so this idea of mentoring really goes both ways. And I tell them that as they go further along in the nursing program, in the beginning, in the first semester, that they're like little deer in the headlights, that look and that feel. They're unsure. They're always fearful of failing. And so I always tell them, failing is not part of our vocabulary, okay? Sometimes you need to step out rather than failing or dropping. And so we put down.
How is the enrollment rate? Do you have the same? Do you see an increased number of nursing students? Has it leveled off? Is it hard to attract students into the program?
No. When we first started this program, I one of my first tasks was to recruit advisory board members. So I approached Native people, obviously, healthcare providers and educators, and non-Native. We need our allies. We all know that. We need to work together. And so one of the persons that I recruited was a physician, Dr. Dawn Frank. She's a administrator for the tribal college in our area. And she said, of course. And so when she came to the very first meeting, she shared with us that she had conducted a survey among the 9 sites of the Oglala Lakota College, a tribal program. She said she asked one question: how many of you are in school to become a nurse? 204.
Oh, wow.
No, because of poverty issues, first generation college students, all the whole array of challenges that we know exist.
Mm-hmm.
We know that maybe 4 will be successful out of that 204.
Thank you, Bev, for those comments, and thank you for being a mentor. I think often we forget how important that is, and it sounds like you're a central figure in why these women are successful. So thank you for your work. Now I'd like to throw out a question to both of you, we've been talking about the importance of reconciliation. We've been acknowledging the past, acknowledging hidden figures, but now as we move forward, as we move our communities towards reconciliation, I'd like for both of you to talk about how do we move forward? How important is that? How do we ensure that moving forward we lift all of our sheroes up in an appropriate manner? Let's start with you, Barb. Dr.
Well, in order to reconciliation to be meaningful and relevant, it has to start with awareness. And part of awareness is knowing your history. So I would like to remind folks that this is the reality as we are in the second decade of the 21st century. 2/3 of the world is non-white and non-Christian. And the 22 million people who call themselves a nurse, the majority of those are women of color. So I want to honor and feel privileged by being able to bring forward 3 Black women of color whose shoulders we stand on, who had a broad vision. They had grit and determination. They were trailblazers, and they had hope, and hope allowed them to overcome fear. And with that hope, they were able to transcend the situations that they were in, but most importantly, from a professional standpoint, provide effective, efficient care. So I'm very proud to be a part of that legacy, and I want to thank and honor them. In terms specifically of reconciliation, I think their story tells what needs to be done. In order for reconciliation to be effective, you first have to have awareness. Awareness means you must know the facts, but more importantly, for reconciliation to be relevant, you have to be empathetic and have an understanding of what is, what was, in order that you can move forward in terms of what must be. So I think the opportunity to give snippets of history brings forward the key elements that are significant for reconciliation.
Great. Thank you, Barbara. Bev, your thoughts on reconciliation?
I will share that just this morning I was at a meeting where we had a speaker who was talking about a new city commission on race relations. And we were all involved with this process. And one of the things that needs to take place, obviously, what Barbara just said about awareness. And another thing that I talked about today was acknowledgement of where each one of us are sitting right this minute, or acknowledging the original inhabitants of this country, acknowledging the land that where we used to be and we were removed for different reasons. And so that history needs to be known and acknowledged. And so now it is happening. For instance, SDSU has a land acknowledgement that does recognize the Oceti Sakowin people, which is the 7 council fires of the Lakota people. And it says it right out, this is where we're sitting today. And part of the reason for that was because they want to increase enrollment, retention, graduate as many Native American students as possible in all areas of study. And so one of the participants of this program this morning said, what can I do? Tell me what to do to make race relations better. And so there was a general kind of a statement back. And I raised my hand and I said, well, I think a lot of what we need to do is self-imposed. What is you can do just based on where you're sitting today. And I said, I would comment that you need to learn about the Native American history of this region. Right now, where we're sitting, the history is very, very telling because it can connect our health disparities to the historical events of this country. And that's one way to do something is to read books that are recommended to you by those who know, and then a book club and share this with each other. And so that would create an individual growth as well as groups of people on this journey for reconciliation, which is so needed in our country.
You're so right. And I want to thank both you and Barbara, Dr. Nichols, for really educating us this afternoon. I've learned a lot. I know that our participants watching have learned a lot. I want to commend CCNA for this Health Equity Action Forum. This is the third of a series. We've been able to delve into some really interesting and important conversations, especially now. None of us can ignore what's happening in our country right now. I often think about how, as recently as 5 years ago, we would talk about a post-racial society, and we know that we have not achieved that goal yet, that we still have a long way to go. And conversations and forums like this and organizations and people like yourselves, you're really living history to help make sure that these hidden figures of the past, but there are a lot of hidden figures today. Nursing as a discipline, I think, needs to build on this history to ensure that Black and brown and yellow communities feel embraced and feel a part of and feel trust in these healthcare infrastructures, especially now that we see the impact of something like a pandemic really exposes our vulnerabilities. I know many people in my social sphere feel more vulnerable today around accessing healthcare than they did 2 or 3 years ago, because there's so many examples of uneven and unlevel treatment. And I think nursing and nurses really can play a key role. So again, thank you both for participating this afternoon. Thank the conveners of this panel. Again, I want to give a shout out to Dr. Winifred Quinn, Scott Tanaka, Jasmine Cooper, who have done so much to pull this together. I also want to give a shout out to AARP and my CEO, Joanne Jenkins, for establishing this new Office of diversity, equity, and inclusion that I get the great pleasure of leading as Executive Vice President and Chief Diversity Officer. In this role, we'll be hyper-focused on both specific audiences like African American, Black, Hispanic, Latino, Asian American, Pacific Islander, LGBTQ, and American Indian, Native Alaskan. We're going to focus on what I call age inclusion, but also age discrimination, as well as really shoring up our internal efforts to focus to make sure that enterprise-wide, AARP-wide, we're able to take on these challenges that are presented today. So I'm really pleased to be a part of this, especially because it's Women's History Month. And I'm so glad that we were able to elevate 5 women today and talk about their history. I also want to talk about, or just mention in closing, that Hidden Figures are not exclusive to women. I mentioned that LGBTQ is one of the audiences that my department focuses on, and I know Wynn tells the story of Walt Whitman, esteemed poet that few of us know was also a nurse. I didn't know that. That was news to me. So making sure that we elevate and celebrate all of those who contribute to the nursing history of the past, but also their experiences, your knowledge, your esteemed knowledge between the two of you. You have decades and decades and decades of experience that we build upon. I'm so glad that you're still contributing, still so vital, still a part of the conversation, because you'll help us figure out this puzzle that we're in right now. And it really is a puzzle. But I think so much of what's been borne out in the last year has been tragic, has been in some ways for me unforgivable, and we really can't revisit. And I think nursing and nurses will play a key role in turning around and making the healthcare infrastructure in the system truly embraced by people of color and communities of color. So thank you all again for joining us, and it's been great. Thank you.